Hi, everyone. Thank you very much. As Dr. Demick said, my name is Lia Delaney. I'm a fourth-year medical student. And today I'm going to talk to you about some of our work we've done over the last year, barriers and facilitators to adoption of a Synoptic Operative note. I have no conflicts of interest to disclose, but notably this work was very generously funded by a medical student grant from SAGES. So, as we all know, hernia repairs are one of the most common operations performed in the United States. And although inconsistent documentation is common across all surgical domains, this is especially critical among hernia repairs because of the number of reoperations and recurrences that occur. And so, what inconsistent and incomplete documentation does is really impede our understanding of an association between different operative techniques and outcomes. Also, it impedes an understanding as we reoperate. So what we did at Michigan was pilot a Synoptic Operative note to standardize documentation of hernia repairs across a statewide hernia registry. And what I'm going to talk about today is how we qualitatively used interviews with these different pilot sites to understand barriers and facilitators to both note implementation as well as variable documentation. And so we did this within the Michigan Surgical Quality Collaborative, which is a collaborative of hospitals within Michigan that pilots different quality improvement initiatives and has a variable registry. 8 pilot sites volunteered to pilot the Synoptic Operative note. And at 6 months, what we did was look at both note completeness as well as variable documentation of these specific hernia variables that we were interested in. And we were actually really excited because at 6 months, we found that notes were more complete. And of these hernia variables that we were interested in, there was decreased missingness across the board at the pilot sites. And so prior to statewide implementation and upscaling this intervention, we wanted to look a little bit closer at what exactly went right and what went wrong, and how this communication got better. So we used qualitative interviews to just take a little bit more of a nuanced look at what exactly was the effective intervention. So at these 8 diverse pilot sites, we engaged with surgeon champions who volunteered to pilot the notes, as well as data abstractors. And the data abstractors were responsible for taking the data from the operative notes and putting it into the variable registry. And so these were the people that we had partnered with throughout the 6 months, and this is who we interviewed to understand what had happened. So these were 20 to 30-minute semi-structured interviews, and we really focused on the implementation itself, as well as barriers and facilitators to it, and to variable communication. And so these interviews were conducted last summer. Of the 8 pilot sites that volunteered to participate, we interviewed 6 of the sites. And what we found, surprisingly, was that only 1 site reported that they were actually using the Synoptic Operative note. So we kind of shifted gears a little bit in these interviews, and we started focusing a little bit more on kind of what went wrong and what went right, because what we did see was that there was increased communication of these variables. So we focused on the barriers and facilitators to this, and throughout this, a few different themes emerged. One of the most impactful interventions and what emerged as a major facilitating theme was communication with abstractors. And so this was really in the form of education sessions about these different hernia variables, as well as about kind of the impact of why this is important, why we care about collecting this data. And all abstractors themselves reported a personal change in their abstraction methods, and also reported that when they couldn't find the data, they communicated with surgeons and asked them to just be better about recording these variables and being more diligent about it. And as one abstractor put, I used to go through the operative notes to see if there were any issues, but now I go through the fine-tooth comb to find all the correct stuff, make sure that I'm understanding the procedure correctly, reading the note better, and filling out the information. A secondary theme that emerged as a facilitator was the acknowledgement of widespread benefit. And this was by both surgeons and data abstractors. Everyone really did acknowledge that there was both a short-term benefit of understanding what happened in each operation, as well as a long-term in understanding best practices within these operations. And so, as one surgeon put, I would love to get the note here if we could. I think it would be helpful overall for the whole state and being able to do future research on best practices in hernia repairs and approaches. We then shifted gears to talk about the barriers, because we did know that although communication increased, we had only 1 site that reported that they used the Synoptic Operative note. And one of the major barriers that emerged was surgeon resistance. And this was resistance to adoption of new practices and change within their workflow. And this was to both the note adoption as well as just note variable completion. As one surgeon put, the only concern I have about this is the feasibility moving forward. I think there's a lack of ability to adapt to new things, teaching an old dog new tricks. And the final barrier that emerged as a major component of this implementation effort was EMR and technology. So sites attributed delays in their implementation as well as just to communication of these variables in general, to not having the templated integrated into their EMR, to having barriers to integrating anything within the technology, barriers from local IT as well as administrative support. As an abstractor put, and this was echoed across the board, it really hasn't gotten off the ground here because it's not integrated into our EMR, which is a pretty major barrier. And without it, there's not much of an incentive to do two notes. So in conclusion, 6 months after the implementation of a Synoptic Operative note, we saw improved communication of these variables. But what these qualitative interviews allowed us to do was give us the information that the quantitative data didn't. It gave us the information of what actually went right and what went wrong. And so we learned that it was not just a Synoptic Operative note that improved communication, it was all of these concurrent efforts that we had put into information, education about these different variables and their importance. And so I think what we can learn from this moving forward is that not only for this intervention, but for other surgeon-directed interventions, really multi-pronged efforts, working with multiple levels of stakeholders and prolonged communication can be really effective. And we're optimistic as well as the future of this because across the board, although uptake was low, there was a really positive perception of the idea itself and the project moving forward. Thank you all for listening and to a great team.